It is 3 p.m. Eastern. We can go ahead and get started. Thank you once again for joining us for today's discussion. This is the QIA land call. My name is O'Neill Delvin. I'll serve as your technical host. And in a moment, you're going to hear from our presenters. Just wanted to provide you with some housekeeping items to support today's discussion before we officially get started. On screen, you can see some reminders, things that will help with supporting today's discussion, letting you know that the lines are currently muted. Will remain muted for the duration of the call to help us with minimizing any background sounds from coming through. But we do encourage that as we go on today, if you have questions, to please feel free to utilize the chat window, the thing that looks like a cartoon talk bubble in the upper right-hand side of your screen. Click that and submit your question to all panelists. And at the end of today's presentation, we'll pause to see if we're able to assist with some of those. Also, today's call is being recorded. Wanted to let you know for internal keeping purposes and such, as well as at the end of the event, let me show you a screen capture that we have to let you know regarding the continuing education units. You will get your certificate. Once we click End Event, a post-event survey will pop up, giving you a chance to provide feedback. And when you are done with answering the questions that you see, and you click Done or Submit, it will then display a page that looks like this, giving you the ability to indicate, are you new? Have you ever joined one of these events before? Or if so, you can click Existing User, and then there's a link. Or if you've never joined one before, you'll click that says New User to give you the ability to set up an account so that you can get your certificate, and as well as for future events. It makes it a lot simple. With that, I'm actually going to turn it over to Julie Moss to assist us with go over a few things. Julie?
Thank you, and welcome to everyone who's joined the call today. We're glad that you've made the commitment to join us, and we hope that you remain an engaged participant in this Learning in Action network. Before we get started, I'm going to provide a brief introduction to who the Esrd Ncc is and what a LAN is. But before we do that, I'm going to turn the call back to O'Neill. He's going to give us a poll question to see what we've got going on in terms of who knows who the NCC is. Perfect.
Okay, we're going to take some time. You should see to the right of your screen a poll that has displayed, and I see a lot of you have already started with providing answers. Really just two simple, or one question, two answer options. I know who the Esrd Ncc is, and they do. So far I see we've received feedback from over 300 folks. Wow, that's awesome. About 400 or 4 or so in progress. So please remember to click the Submit button. We can tally your answers with the others. And sorry, but we're going to have to I'm going to get down a little bit to give us a chance to continue the presentation, of course. So just click the Submit button, 2, and we've got to close the poll, and 1. Perfect. So let's go ahead and close this out. If you not get a chance to participate, it's fine. Two questions just to see who we have on for today's discussion, and just one moment while it's currently processing the feedback that we've received, and then we have one more poll question that we'll display in a moment, and then we'll continue from there. So based on the feedback that we've received, Julie, just give me one moment, and it shows that it's actually split. I see on screen about 57% says no, and about 41% of those who've replied said yes. Julie?
All right. Thank you, O'Neill. And thanks, everybody, for participating in the poll. And so we've learned that about half the group that was able to get the poll completed knows who the NCC is, and about half don't. So let's take a minute here and talk about what and who the Esrd Ncc is. So the End-Stage Renal Disease National Coordinating Center is contracted by the Centers for Medicare and Medicaid Services and serves as the hub for the 18 Esrd networks, functioning as a knowledge repository of network-related information, including best practices and lessons learned, and performing aggregate data analysis and interpretation of data for the networks that comes in from the networks. So we reproduce that and send it back out after it's been analyzed. The goal of the Esrd Ncc is to provide leadership, coordination, and support the achievement of common quality improvement goals for the 18 networks, while providing a single communications and organizational vehicle for the government to achieve the strategic goals of the Esrd network program on a national level. So we're going to be spending a lot of time together in these QIA activities in the coming year. We'll spend a little bit more time getting to know our members, and we hope you spend some time getting to know us and use the chat box to ask us some questions. In the meantime, we're going to go up to our second polling question for our call, which is, I'm going to turn this back over to O'Neill, who's going to put up the poll question regarding I know what a LAN is.
All right, thank you so much. All right, so this next poll question displayed to the right of the screen, same thing. Just answer options. I know what a LAN is, just yes or no. Just make your selection and click the submit button. And once you click submit, we'll close it out and just share the results once again. And then we'll continue from there with making sure that we jump with right into the presentation, giving us a chance to hear from our presenters today. So, all right, so they have received about 600 or so folks. Thank you so much for sharing your thoughts. I'm going to do a quick countdown. 3, 2, and 1. So we'll go ahead and close this one out. And again, you're not being graded or anything for this. Just wanted to see who we have on for today's discussion. These 2 poll questions. So just give it one moment for it to finish processing, and then we will share the results with all, and then we'll continue from there with hearing from our presenters today. So, all right, let's finish rendering, and the results displayed to the right. And Julie, it shows close as well. About 52% says no, and 44% of those who answered said yes. They know what a LAN is. Julie? Okay,
great. Thanks, O'Neill. So we're going to move on here, and we're going to talk about what a LAN is. Learning and action networks are mechanisms by which large-scale improvement around a goal is fostered, studied, adapted, rapidly spread, and sustained, regardless of the change methodology, tools, or time-bound initiatives that is used to achieve the goal. So it's really about bringing best practices, promising practices, next practices together and finding what is sustainable, workable, and usable, and making it spread to a greater community. A LAN is made up of a group of healthcare professionals, stakeholder organizations, and patients and families who come together to improve patient care or population health and spread best practices through peer-to-peer learning and solution sharing. LANs evolve and operate best when everyone teaches and everyone learns. This and other LAN calls are designed to explore how promising and next practices become sustainable best practices that are adopted by the intended audience for the advancement of person-centered care, which ultimately improves the quality of life and care for all patients. We're talking a lot more about what LANs do. They're action-oriented and request a lot of communication from the members. So we're going to be talking a lot about that this year. But for now, I'm going to turn the call back over to O'Neill and our presenters.
All right, thank you so much, Julie. Lisa, I do see that you're connected. Let me just unmute your line real quick, see if there's anything that you wanted to say to the group before we officially get started, and then I'll turn over to Deb to get us started with today's call. So, Lisa, if there's anything you'd like to share with the group, thank you.
Appreciate everybody that's joined, and I hope we can have a productive call. Thank you very much.
Thank you, Lisa. With that, Deb, I will turn it over to you. Thank you.
Okay. Good afternoon. My name is Debbie Bowe. I'm the Quality Improvement Coordinator for the Midwest Kidney Network. I have dialysis since 1974 in various ways. Our keynote speaker is Rochelle Whitmore. Rochelle served as the Renal Dialysis Program Director at McLean, Northern Michigan for the past 5 years. She helped with dialysis nurses, nephrologists, and CRRN, Northern Michigan Sepsis, and special project coordinators on innovative approaches to identifying and preventing sepsis in patients on dialysis. Additionally, Rochelle holds a Master of Science degree in Nursing Leadership from Walden University. Next slide, please, O'Neill. Thanks. Infections are the second leading cause of death in patients with end-stage renal disease. As a result, the Centers for Medicare and Medicaid Services, or CMS, has set the following goal. By 2023, reduce the national rate of bloodstream infections in dialysis patients by 50% of the bloodstream infections that occurred in 2016. To accomplish this goal, each unit must develop ways to reduce infections within their own environment. To this end, a unit from our 2017 Bloodstream Infection Project has taken this goal and run with it. The dialysis unit at McLaren Hospital in Michigan has done a remarkable job in identifying the causes of their infections, and they utilize their hospital resources to develop a program of patient assessment to prevent infections. It is my privilege to introduce Rochelle Whitmore. We first Rochelle with her 2017 Bloodstream Infection Project. And talking to her, we realized her unit had developed an amazing process of infection detection and sepsis prevention. So happy she is here to share her unit's effort and outcomes. So, Rochelle.
Welcome. I had the opportunity last year during a webinar to present our performance improvement project on reducing bloodstream infections, and really appreciate the opportunity again to provide an update on what we did, how our data improved, and what we're planning this year, because as we all know in healthcare, there's always continued room for improvement. O'Neill, slides aren't advancing, so do you want to take control of it?
Sure, if you'd like. I gave you the presenter ball. If you click anywhere on the slide itself, and you can use the space bar or the page up, page down, or I can take the ball. Here you go. Yeah, thank you.
Yeah, thank you. Okay. Give me a second.
You're currently on slide. If you'd like, you're currently on slide 1. If you click the deck and then you can hit the space bar, it will advance to the next for you.
Okay.
There you go. There you go.
All right. Thanks for your patience. So this slide represents a number of bloodstream infections that we had in 2016 and 2017. As you'll notice, many bloodstream infections were not access related. In 2016, for instance, there were only 2 infections attributed to the dialysis access, and made a mistake early on in our initial thinking that we really couldn't do anything about the fact that many of our patients were developing bloodstream infections for conditions like pneumonia, osteomyelitis, urosepsis. We had a post-surgical case of sepsis following gallbladder surgery, etc. So towards the end of 2016, early 2017, we realized we had to come up with some innovative way to affect better outcomes after completing a root cause analysis and dissecting each individual case. We found our patients were ignoring some health conditions that, if recognized and treated earlier, wouldn't have resulted in a bloodstream infection and or the subsequent hospitalization. So we assembled our interdisciplinary team and we reviewed evidence-based resources on a variety of assessment tools in an attempt to aggressively reduce our bloodstream infection rate in our patient population. And as a result, the numbers of events went down from 10 in 2016 to 7 in 2017. However, we didn't launch our actual performance improvement project until late April, early May. I was really disappointed by only reducing the bloodstream infection events down from 10 to 7. It didn't seem that impressive to me to only be 3 events under what we had the prior year, considering all of the effort that we put into developing our performance improvement plan. But I do know that every case matters. Because when you look at this slide, our standardized infection ratio, or the CRR, went from 2.008 in 2016 down to 1.459 in 2017. I know we have a varied audience on the line, so for those of you listening in that may not know what the CRR represents, it's basically a summary measure used to track healthcare-associated infections at national, state, or local level over time. It does adjust for various facility and or patient-level factors that contribute to healthcare-associated infection risk within each facility. So basically, our CRR tells us that in 2016, we had 5.02 more infections than we should have had for our patient population. And CRR in 2017 demonstrates that we actually are making progress, and we are closer to our destination goal, which is a CRR of 1 or under, preferably under. If we could just prevented more infections, we would have achieved that. So instead of being discouraged, understanding the measure provides us with renewed encouragement, motivation, and continued intensity, because we want to be industry leaders in significantly turning around our results in 2018. So I want to review the action that we took as part of our performance improvement plan in 2017. We took specific actions in the following areas. We administered a survey to our patients that was intended to assess their level of knowledge regarding sepsis and bloodstream infections. Prior to education, we completed education, and then we resurveyed them, and it helped us to identify whether learning had occurred. We launched our staff education as well as patient and family education focused on signs and symptoms of infection, what sepsis is, the seriousness of it, and what actions to take to improve performance or reduce the occurrence. We also created a new screening tool, doing a number of evidence-based resources such as the CRRS, MEOW, SOFA, and QSOFA tools, but we modified some of the clinical parameters to fit our specific patient population. I'll cover the screening tool later in one of the slides that focuses just on the tool. But the goal of the tool is to direct focused assessment and identify earlier the subtle signs and symptoms of when an infection develops. It also provides the guidance for nurses to assertively take action in response to identifying some of these changes in the patient condition. And resources from a variety of sources. In the upcoming slides, I also copied some of these resources and included the online links so that you can find them. I do want to underscore the importance of completing meticulous audits during patient care activities. We complete monthly audits on hand hygiene, cannulation and decannulation procedures, catheter handling, and station disinfection. The resources are available to anyone, and they are easy to use. It is probably a good idea to train a few different staff members on how to complete these audits and have them participate in direct care observations. It's always eye-opening when you know people know how to do things the right way, and yet you observe variation in practice, and it is impactful when you're able to provide real-time feedback when you see it occur. We had recently, last week, the hospital infection control nurse come over and complete some of these audits for us, and it's just a value to have an extra set of fresh eyes on your technique. Also, 2017, at the tail end of the year, I joined the Sepsis Excellence team at the hospital, and it helps me to link with the hospital with a two-way flow of information regarding best practices. Lastly, we conducted an informal and anonymous audit of patient compliance with health hand washing. We do this with our staff, but it is interesting when you plant someone at the nurse's station. Everyone else is busy, but if you have a designated individual just to watch your patients, what we found was that not everyone was compliant with washing their hands and their access site upon arrival. Some were even argumentative with us when we reminded them to do it. And some of the comments included, well, I took a shower this morning, or my wife washed my access arm. We had many teachable moments with some of these individuals. And at some point, we made a facility decision to provide sanitation wipes chairside for every patient every single day. So if they were observed not washing their access arm upon arrival, or if they couldn't confirm with believability that they did it, we send them a Sani wipe and indicate that we can get started with their connection once they complete that step. This was received with some initial grumbling because people want to get in, get on, and get out. But it did help us to achieve better validation of patient compliance with hand washing. Early on, we had situations where the white antiseptic pad turned visibly soiled after cleansing the arm, which was a great way to demonstrate to a patient how if you think you're clean, you might not be, because it's pretty believable when you can hold the little white antiseptic wipe up and it's visibly soiled. So what we're planning in 2018 is to resurvey and re-educate. We've got a number of new patients, and we know that some of our patients have forgotten the information we presented last year, so it's an ongoing process of education. We also started passing out the surveys again this year, and it is surprising to me to look at it, and after all of that emphasis and education and one-on-one conversations, when you have patients on your surveys marking, I don't know, when they're asked a basic question such as the CDC reminds or recommends washing your hands often, especially before and after dialysis treatment, and answering, I don't know, it's eye-opening. So it is good to have some surveys to get a feel for where your patients are at with their knowledge. We're in the process of looking deeper at our data, including sepsis versus severe sepsis cases, the length of stay, the mortality and costs associated with care. We're a hospital-based program, so it's nice to be able to partner up with people at the hospital to be able to do a deeper dive in what's really going on with some of those cases. But interestingly, I'd already noticed that some of our patients that have been hospitalized for sepsis haven't always developed a bloodstream infection. And I received feedback from the special projects coordinator at the hospital that our dialysis patients, they've noticed that now when they're coming in for a suspected infection, they don't look the same way that they used to. She's convinced it's earlier identification, and those people aren't showing up with the late clinical indicators of what would be classified as a severe sepsis case. She also asked if I would participate with her in providing outreach to the other dialysis units or the nursing homes, provide education regarding our particular performance improvement project, and encourage other clinicians to coordinate care earlier when subtle signs and symptoms are identified. Also for 2018 is in April, the American Nephrology Nurses Association is having their annual symposium. I did submit an abstract about this project that we're doing, and it was selected to be displayed as a poster presentation. So we're hoping by attending that conference in Las Vegas that we'll be able to pick up other best practices from across the country. We have a robust year planned. This is a long slide, but we did also struggle with having too many catheters. And I have been trying for almost 9 months to confirm an appointment with a surgical practice regarding collaborative strategies in reducing catheter rates. We finally got confirmation after a really long time that we are invited to the boardroom where we will have probably the undivided attention of at least 6 surgeons, where we'll bring to the point and brief presentation about our performance score report, our quality measures, information on catheter reduction and fistula catheter last initiatives, as well as introducing them to a new access assessment tool that I'll show you later in one of the slides that we'll be adopting in 2018. We are going to let them know that they can expect to see that tool in the upcoming year. We'll be sending it to their office with our patients and empowering our patients to have discussions about it. And the reason why we requested a meeting is that sometimes instead of scheduling the quicker appointments to fix access issues, that there's been a recent shift in placing a catheter, which is not, well, we all know that that's not the right course of action to take. We did have some feedback from a relatively newer patient on dialysis in her early 40s that said that after an appointment she was instructed that her vessels are too small and she was a candidate for an arteriovenous fistula, and so the catheter subsequently was placed. So we know that we need to be able to assertively communicate and collaborate on better options, because a catheter in a patient that young is not a feasible long-term plan. So I guess my point here is to never give up. Find a way to get in front of those people that you need to partner with to improve outcomes. With regard to competency validation, we complete our annual competencies. People know how to demonstrate technique when you're in front of them, but we're going to take it another step. When we do our audits, have random sampling of people. This year we're going to require that every single staff member not only presented their competency with catheter handling mannequin in the classroom setting, but then we will require all of them to have one other person validate their competency in catheter handling at least 3 additional times in the clinical setting. And we're pushing the repetition and the ingrained adherence to policy and best practices, especially when you're in a hurry. Something that we noticed through our audit process, that speed doesn't trump procedure in practice. We are definitely lucky enough to have a number of generous donors, so we are embarking on a way to update our training and our simulation lab to further help with competency validation and onboarding of new employees. And lastly, this year we're going to focus a part of our training content on empowerment to be able to connect with staff and patients on a different level to improve outcomes. And part of that discussion will be promoting assertiveness, not only to our staff member, our nurses, but our patients, not to just sit back and wait for things to happen, rather empowering people to overcome a sense of powerlessness and perceived lack of influence and make things happen to preserve their health and wellness. We had an example last year of a patient who had insisted on keeping her catheter and canceling and skipping surgical appointments for access work revision. We had the nephrologist, 2 different nephrologists go in, the nurses were talking to this person, social work, technicians, all having independent conversations with this individual, and we just could not persuade her to follow through with getting her access functional and the catheter removed. She was one of the infections in 2017, and it occurred right after we had just talked extensively about sepsis education and reducing bloodstream infections. I am contemplating on approaching this individual to become an empowering voice for others, seeing if she's willing to be a champion for catheter removal from a patient's perspective and to provide testimony to the seriousness and scare that bloodstream infection can cause if you're unlucky enough to develop one. Here's a summary of some of the tools and resources that we used with online links to be able to find them if you're interested in using them if you're not already doing so. I like the 6 tips document because one side addresses catheters, and I think the other side is purple, and it addresses tips to preventing dialysis infections with regard to fistulas. So like the color-coded stoplight reference, as you can see on the bottom 2 tools, it helps to tear up a sense of urgency through color, if you will, when helping a patient decide how to feel and what they need to do about it. We kind of like the infusion of color. They seem to relate well to that rougher tool. This is an internal tool that actually I didn't develop it. Our hospital sepsis coordinator developed this. It's a dollar bill-sized wallet card that we can distribute to our dialysis patients. Again, it has the red, yellow, and green theme in a trifold card. One side covering the signs and symptoms and what to do, and the other side reminding patients of what sepsis is, the treatment they can expect to be ordered when they go to the hospital, and a section to document their normal or baseline vital signs, their medical history, allergies, chronic conditions, and who their patient advocate is. Probably everyone's familiar with this in the dialysis industry, the scrub the hub policy. I just included that because that's something that we use as well. The checklist we use for arteriovenous fistula cannulation. We had one patient from each shift complete this form on our technique last year, and we probably will have that our patients participate in checking us off on our audits as well, and I'd be interested to hear if anybody else is doing that with their patients. more tools and resources on catheter connection and exit site care. And it's one example of a nurse that had completed the audit on hemodialysis station routine disinfection. You see there are 2 nurses and 5 technicians were observed. We do initially focus on like the person, that's why we don't put names on there, rather on compliance with the results. However, if the auditors do notice that there is a particular pattern with a specific person, then that becomes a performance issue which is addressed individually. I love this poster you're seeing on the screen. We're now displaying this by our time clock. So when people come into the department and they punch in through the phone, this poster is laminated and it's right there, and we keep a rolling tally of the number of days that we've had without an infection. It's pretty powerful to keep it front and center for everyone. And this assessment tool that I spoke about earlier that we will be taking to the meeting with surgical practice, it is a succinct place to include your relevant assessment details for the surgeons to review at the patient appointment. But what I also like about this form is the interventions and comments box on the lower right-hand side is a space where you can document what has been attempted, as well as be specific regarding what you were as a nurse or what the nephrologist would like to see happen at the appointment. I did go in 2017 to the Area Agency on Aging and did a presentation on sepsis awareness, and we showed this. This link is to a about 1 minute 50-second video on sepsis, and I like it, and I probably will present this or show this in our waiting room, as well as go chair to chair if needed, so that all of our patients see it. It's a pretty simple, easy, and quick demonstration in a video format on how to prevent infections. This was our initial survey of our patients, where we had 68 participants last year. What was interesting is that 63% didn't know what sepsis was, and the next percent, 63%, didn't think it was a medical emergency. And a high percentage, 82%, did not think they were at risk. And in the end-stage renal disease patient population, we know that they are at risk. We'll be resurveying our patients again this year and presenting more education. This, when I went to the Area Agency on Aging, demonstrates that at a community level, it was a slightly different survey, but more people seem to be informed about sepsis. And they definitely caught me afterwards and wanted to tell me their story. Their powerful voice, because a lot of them had traumatic experiences. They were sick enough to be surprised that they survived the event. Not everyone took to complete the post-survey, so there were only 18 participants that completed the survey after the education, but what was interesting was seeing the scores and move to 100%, which should demonstrate that they were attentive to the information I presented to them. Names of the screening tools that we reviewed before developing our own sepsis assessment screen. What we found was that the vital sign parameters didn't really fit our patient population, since they already have organ failure. And as we know, can be outside of the normal range, if you will. We also couldn't find any tool that addressed the ambulatory setting, where in this vulnerable patient population, early identification is so critical. So the tool, here's the form. It's a 2-week double-sided form that contains assessments for each day. So 3 days when they come in on Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday are on one side, and then the second week is on the flip side. So you actually have the ability, even though we don't like paper anymore, it is a way to have an ability to track assessment variations. This is a blown-up view of a single day. It is in subjective patient-reported symptoms portion at the top. We are asking more detailed questions about specific signs and symptoms that they may be experiencing when they come to our dialysis unit. For instance, do you have a cough? Did you notice any wounds or breaks in your skin anywhere on your body? Some patients that maybe still have some urine output, we ask them if they have any burning, urgency, or pain, because remember, we had a number of urosepsis cases. About the specific fever, chills, all of those questions and symptoms that you might find during a septic event. The objective clinical measures section in the middle allows you to score points when the actual readings fall outside the range. There are total points that are tallied. A clinical response box at the bottom, which is color-coded, is where the nurses are directed to take specific action based on the score. So you score the subjective symptoms, the patient reported, or if some people don't have any issues, but we might notice they have a cough. So we'll put number tally in the yes section. So you tally up the score, and then you use the clinical response in the green, yellow, or red zone to identify what needs to happen next. We have noticed a few things since implementing this form that you cannot dismiss by any means the need for nursing critical thinking and clinical judgment. For instance, if you have a patient that had a catheter who maybe had a procedure, say a thoracentesis the day prior, and came into your dialysis unit and was assessed at baseline with no other symptoms present, you would technically score a 2 in the yellow zone box automatically. They get a single point for a catheter, and they get another point for having undergone a recent procedure. But necessarily call a primary care provider as it's directing you to do in the yellow zone if other signs and symptoms were not present. We would meticulously, at the next appointment, assessing for any issues because it would be obvious that that person flagged in the yellow zone at the last treatment. So you'd be able to slipping into a clinical situation that is problematic considering their baseline assessment. Also, it's not on this slide, but on the prior slide on the 2-week form, there is a space where nurses can put comment in a notes action section, and we've noticed that our nurses here are doing that so that you don't have to, you might have a different nurse the next day, but you can easily see that this nurse made a clinical judgment maybe to not call the provider because there wasn't a concern this person was at their normal baseline. But then if the nurse following on the next scheduled dialysis treatment session noticed maybe this person is a little more confused than normal, or physically they're a little more fatigued or developing additional signs and symptoms that would be concerning, that would be a way to pick up on that. And then maybe, yes, absolutely contact the primary care provider. Certainly if they're in the red zone, we have definitely taken a more assertive stance in helping patients schedule same-day appointments with their primary care provider if you have enough of a concern where they're lagging in the red zone. We're telling them to go to the ER, or we are picking phone and calling their primary care provider and asking if they can squeeze them in for an appointment. It's been our experience that dialysis nurses see these patients day in and day out, and we can sometimes tell even before they spike a fever that they're just a little off. They might have some subtle confusion or something's just not right, and that's, I think, where we can really leverage the earlier identification. Okay, so at this point, O'Neill, could we pause and see if there are any questions to review via the chat window?
We've received a few, actually, and this is a good point to pause and say, folks, if you have any questions regarding the material that's being covered, please feel free to utilize the chat window and send messages to all panelists. And we had actually about 4 or so that came in, so we'll pause for a moment. One, since we're on this slide here, question of do you score 1 point for each yes in the top box, I believe, as it relates to this information you're currently covering right now, Rochelle. And then we have 3 more.
Yeah, do score. And, you know, you could have someone that's just sick that is scoring in the red zone, and there's some clinical judgment that you've got to leverage. Sometimes the nurses put their heads together with the nephrologist or with the other staff to make sure that you're not overreacting to a situation. It's definitely a score for each symptom.
Another question I see is, our medical director is apprehensive about adopting the sepsis assessment tool because he thinks it will create more calls and pages to address primary care medical care issues. Did you meet resistance, or did you meet resistance initially when implementing this tool in your unit?
Well, then we presented this idea through our QAPI meeting and talked to the nephrologists about, well, we developed the tool first and then we put it in front of them, and just to see what reaction we would get. We did stress, however, these are going to be calls to you because you're managing dialysis. And we're identifying that a lot of our cases in 2016 and 2017 had to do with lack of attention to their primary care needs. And this isn't, you know, to say anything, this is from patients not seeking the assistance from their primary care provider so that they stay healthy and well. And so we reiterated that this isn't necessarily us paging the nephrologist to deal with issues. This is us taking assertive action with primary care office to be able to coordinate care, to keep these people out of the hospital. So I would assure your medical director in the dialysis unit that you would be following the clinical response, not necessarily calling them first, but calling whoever their primary care provider is, keeping the nephrologist in the loop about our concerns. It seems to work pretty well, and I have some success cases, at least one, that I'd like to share at the end.
There's 2 more questions, and then we'll go ahead and continue with the presentation. I know that we have about 17 minutes or so remaining. The next one that came in a little bit earlier is, have you noticed a difference with your patients taking more ownership regarding their health and well-being?
We have noticed patients taking more ownership of the care. We've also noticed so the other question I think someone else asked me about this tool is is it labor intensive? It does take time. It adds time to the nursing tasks. However, now they've memorized all the questions, and so as they're hooking people up to machines, and they're talking through some of these assessment questions, as well as our patients now have memorized what they're going to ask them. And we used to see routinely where a patient wouldn't disclose that they had a gaping wound on their foot, and we would find out because we'd see the emergency room report. And this has been a change in patients then disclosing a little more information about their holistic care and health status. This is just, how are you doing today? Do you have any nausea, vomiting, diarrhea? It's definitely more system-focused and specific. So one of the interesting things that we've noticed that some of our patients won't tell one person they're having issues, but then because we're being more detailed about our line of questioning, they might disclose it to their favorite nurse or text later, or maybe even a day after. And patients wait and even tell the dietitian or the social work that something was going on or they had an issue when the nurse had just completed the sepsis assessment. So it's interesting how they're responding to us in this new process. It just makes you wonder if there's some degree of trust or comfort that plays into their transparency regarding how they feel on a daily basis and their willingness to pick out those people that they're comfortable with to talk about it.
So much, Rochelle. One more question and give you a chance to continue with the remainder of your presentation, and we'll pause again at the end to see if we have additional questions that came in, which actually I do see additional questions came in, but we'll see, again, time and so on. But the last question that we'll cover for right now is the tool time-consuming for staff to complete?
It adds time, but again, it's a little cumbersome at first. But once you get it down, I mean, it's not that labor intensive. Again, because you start to memorize the clinical markers, you don't even, sometimes the nurses don't even necessarily have the tool in front of them. They're just asking the questions. So,
Rochelle, you can go ahead and continue. Thank you.
So talk about just a case review. We recently had a patient that resides in a nursing home develop a terrible cough, which we know it's going around this time of year. The cough had gotten progressively worse. Used a communication report. We always do with our patients that reside in nursing homes to communicate what their vital signs were on dialysis, as well as they let us know what meds they gave. So we do use a communication tool, but the cough had continued to worsen and started to cough up thick green brownish phlegm into the mask that we had her wear in dialysis when she showed up, and it was requiring multiple changes to keep it clean. We decided to pick up the phone and call the nursing home staff. I was able to speak directly to the registered nurse taking care of the patient. She told me that the person had been placed on Tamiflu at the onset of symptoms. I asked whether she was on any nebulizer treatments because of the thickness of secretions and her difficulty in expectorating those out. She said would place a note in the doctor's box and let him know. So a few treatments later, she continued to cough. I happened to be in the dialysis unit, and the staff let me know that it took 3 staff members to transfer her from the wheelchair to the dialysis chair, which is really unusual compared to this person's baseline. So I asked the nurse that was taking care of the patient to call the nursing home again and to just be a little more assertive in asking what, if anything, had been done for this particular resident that seemed to have now a physical decline in her condition. So long story short, she was subsequently evaluated by the provider and started on an antibiotic. I know that her symptoms started out as viral, but it progressed to needing an antibiotic, and she looks way better this week. I'll know that there's a fine balance with antibiotic stewardship and not chasing after those drugs too quickly, but our new process helps us to see that over time, when the patient's clinical condition is worsening to the point where you only have a few days or a few hours until they're going to show up in the emergency room, it's just been a good empowering tool to be able to use, and really empowering to assertively have those conversations and collaborate for transitions in care. Notice, the question is critical. You can't always assume that someone else is on top of it. To advocate for your patients and coordinate transitions in care, it takes assertiveness and empowering the nurses and patients to speak up to direct care. So I just wanted to put this slide up here. I like the word empowerment because these measures we are taking are inherently designed to improve the degree of autonomy and self-determination of our outcomes. We are helping our patients to be responsible and better speaking up about how they feel so that they can participate in determining their healthcare outcomes. It is the professional support of our dialysis nurses that are more aggressively helping patients to overcome that sense of powerlessness or dependence on someone else to take action and get them to believe that they actually can influence their outcomes or their destiny.
All right, Rochelle, thank you so much for a great presentation. I do see that we have questions that we received via the chat window. We have about 10 minutes or so remaining for today's discussion, so we'll pause for a moment and just ask Rochelle as well as Deb and the folks at Network 11 to assist us with answering some of the questions that we've received. The question we see at the top is, are you able to draw blood cultures and empiric until culture reported?
Yes, those in our department. They'll give us that order so we can initiate that process.
Thank you so much. Next question I see, do you have issues with patients not having a PCP and seeing the nephrologist to treat non-dialysis treated issues?
We rarely see issues with someone having an identified primary care provider, and on the rare occasion, if they do, we've helped them find one and get an appointment. Their healthcare needs are too complicated to not have someone that is well known to them to address their issues. We're fortunate, we're in a wellness center, and one of primary care providers actually has an office just down the hall. So we try to encourage, assist people in having an identified primary care provider.
Here's the next question, and I apologize if I asked something that you've touched on a moment ago, but this one is, what do we do if a patient does not have a PCP? This person says that my facility, many of our patients at my facility does not have one.
We just recommend, depending on if they're in the yellow or red zone, if they're in the yellow and we just have a suspicion that something is going on, and again, dialysis nurses and technicians seem to know their patients pretty intimately because we see them so often, unless, of course, it's a new patient. If it's yellow zone, I would be highly encouraging them to pursue or schedule an appointment at a walk-in clinic. If in the yellow zone, and if they're in the red zone, definitely directing to the emergency room. And I'll give you an example. Like, we had a patient that flagged on sepsis screen, definitely is not always the most compliant person with diet and everything else, and was in the chair one day, and the nurse assessed her in the red zone, and she had reported symptoms, chills during the treatment. She might have even had some blood pressure issues, if I remember the case well. She was instructed to leave the dialysis unit and go straight to the emergency room, and she didn't. She went home for like 6 hours and then presented to the emergency room and definitely had severe sepsis diagnosis and a bloodstream infection. That was our last case in the year. We're doing a better job assessing and identifying. That's why I put empowerment in here. We have to connect with patients on a different level so that they understand that you're about your health, but you have to understand the risks of not seeking treatment when it's appropriate for you to do so.
Much for sharing that. Just want to mention as well, we did receive a couple questions regarding if the recording and such will be made available. Just wanted to let you know, for those of you who are on, yes, it will be made available, so you'll get an email regarding that. But also a question for you, Rochelle, I see this one is saying, for the symptom review slide, I'm not sure if you want to go back to that one, you still have the ball, but for the symptom review slide, what time frame do you use, i.e. have you felt your heart racing in the last 12 to 24, et cetera, hours?
Use a line of questioning and say since your last appointment, since your last dialysis treatment. Have you fever, chills, has your heart is racing, shortness of breath, since your last dialysis treatment?
much. I'm just going through right now, seeing, here we go. Let me see this question here. What type of wipes did you use for patients to clean access?
We purchased these PDI Sani wipes. And actually, the hospital ordered them for us like in a bulk package, but we wanted single use, one per chair, every patient, every time. So they're called PDI Sani wipes. They are 70% alcohol, 70%.
I see another question that came in. I'm just going to read it as submitted. This one is a little long. Here we go. It says, would you consider it a good practice to use antiseptic cleaning wipes on all patients, AEF and AVG, prior to cannulation, regardless of if they wash their access prior, still urging every patient to wash access, of course?
That question to one of the other presenters or the listening line?
So, good point. Let me see, Deb, if you're still connected to the audio, or Kristen, let me see. Let me just go right now, see if your lines are currently muted. Oh, are you muted or unmuted?
No, Deb, I'm on.
Right.
I'm understanding the question as if the patients don't wash their arms. Patients are supposed to wash their arms when they come in. If they don't, you can use Sani wipe, but then you're also still prepping the two areas that you're going to be putting the needles.
Right.
If you're going to be putting the needles, you need to do a separate cleaning in that area. That answers your question.
For adding to that, and for the submitter, if that didn't answer the question, please feel free to use the chat window to submit question or comment to us. I believe we have about time for maybe one or two more questions. I'll ask the next one. Is 2 BSI, both of them were not related to dialysis related IGU source. We treated them. So I'm not sure, that's not really a question. I believe that's just a statement. I don't know if you want to add into that, but I can move on to the next question if that statement.
They may be asking, does that count? And it does. If it's, even if it's not an access-related infection, if it's an abdomen infection, no matter the source, it does count for the dialysis unit.
Here we go. I see a question. When you implemented the audit that the patients did not, when you implemented the audit that the patients did on their caregivers, what was the initial response from both the patients and the caregivers?
If people stand to attention, people meaning caregivers, that you're gonna what? Pass that out to the patient? It makes you sharp really fast, knowing that your patient's got the answers to the test right in their hands as you're performing the procedure. I think it was well received. I mean, when you talk transparently, not only to your staff, we didn't have great results, which is why we embarked on this process, and I know we are going to tackle significantly reducing our rates. Because we've talked transparently about it, and we're involving our patients. I think our patients appreciate knowing that we could be doing everything right. We want you to have confidence that we're doing everything right by giving you and empowering you with the sheet to check us off. But there's also things that you need to be doing that you don't have control over. If we are having to publicly disclose that our infection rates are problematic, if we're doing everything we can, but our population is not, we need to be on the same page with what we're doing. I hope that answers the question.
Thank you so much, Rochelle. I'm not sure if there's any final comments or thoughts that you wanted to share before we officially work towards wrapping today's discussion up, but of course we just want to say thank you so much for spending some time to share with us on today's call.
I do one last thing to say, which I just want to underscore that this is not a researched tool yet, unless someone wants to research the validity and reliability of it. We just created it as a mechanism to help improve performance, and I think we're seeing some initial stages of that. I guess we implemented it part of the way through the year, and we hope to see continued increased improvement and reduction of infections.
So much once again, and everyone, thank you so much for joining us for today's discussion. I do see that it is 4 p.m. Eastern. We'll work towards wrapping things up. Once we end today's event, as mentioned, a couple reminders. A post-event survey will pop up, giving you the ability to provide feedback. And once you are done with that and you click the submit button, you'll get information regarding how you can obtain your CEU certificate. Also, today's call was recorded, and we'll make the recording available immediately after the call. So thank you, everyone, once again for joining us, and have a great day. Thank you.